can go ahead and get started. Yeah, so we have a good lineup today. Nikki Zarling, Dr. Zarling is going to be giving us a talk on polycystic ovarian syndrome. And then that will be followed by Kellen Hirsch giving us a talk on pulmonary hypertension. After that, we'll split the crew. Seniors will have an early morning and have some time for themselves, whereas interns at 10:40 will go to intern core curriculum in Test King's Zoom room. So look to your email for that link when the time comes. But otherwise, I think we're ready to go. So Nikki, you can take it away.
Yeah, that works for me. My name is Nikki Zarling, and I'm one of the R2s in the Women's Health Pathway, and I'm really excited to be talking to you guys today about polycystic ovarian syndrome. To start off, some disclosures, of which I have none, although I would like to be getting paid in order to be talking about this kind of stuff. But I first want to launch into just talking about what my learning objectives for today's talk is. So the first thing we're going to be doing is listing the diagnostic criteria for PCOS. We'll work on developing a basic differential for patients presenting with symptoms concerning for PCOS. We'll identify some of the common comorbidities associated with PCOS. And at the end of the talk, we're going to briefly examine how racial or weight bias might play a role in diagnosing and managing PCOS. So in terms of a little bit of a roadmap, first, we're just going to talk about what PCOS is, which is one of the most common endocrinopathies in the United States. We'll talk through the diagnostic criteria, the differential for patients experiencing the symptoms consistent with PCOS, discuss the basic lab and imaging evaluation that you can get in the primary care setting, and review some of the common medical conditions. And then, like I mentioned, we'll touch on some equity considerations. And at the very end, we will be doing a very short quiz to test our learning. Although there are multiple scoring systems used to define PCOS, the most commonly used criteria at this time is called the Rotterdam criterion. And there's 3 components of this score. The first one is hyperandrogenism, which is via lab testing or clinical signs. And we can talk a little bit more about what that means on the next slide. The next feature is menstrual irregularities or irregular periods or no periods at all. And the last is polycystic ovaries as seen on ultrasound. And you need 2 of these 3 criteria in order to be diagnosed with PCOS. And given the prevalence of PCOS, we should be asking these questions, screening for these conditions as part of our normal history for reproductive age women. I also want to say early on that PCOS is a diagnosis of exclusion, and you need to rule out other causes of these findings before attributing a patient's symptoms to PCOS. So let's talk about these diagnostic criteria in more detail. The first one is hyperandrogenism, and we can look at either clinical features, which are things like severe acne, hirsutism, and even male pattern baldness or androgenic alopecia, and then also biochemical features. This is a graph that shows that patients with PCOS compared to those without have elevated levels of different androgens in the bloodstream. Although either can be used in the diagnosis, most patients with clinical features of high androgens will also have elevated levels of androgens on lab testing. Signs of severe androgen excess, like voice deepening or an enlarged clitoris, are far less common in PCOS and should increase suspicion for other causes of symptoms, like an androgen secreting tumor. So as I was researching this talk, one of my big questions that I wanted to get out of it was, what is hirsutism anyway? It seems like something that was a little bit challenging to kind of definitively diagnose. And it turns out that there's a validated scoring tool that we can use to evaluate for hirsutism called the Ferryman-Gallwey Hirsutism Scoring System. It attributes a score from 0 to 4, depending on severity, of 9 body areas that are most sensitive to androgens. What you do is you would score each of these areas with the patient, and then the sum of your score is your final score. So, if you had a level 2 upper lip hair, a level 3 chin hair, et cetera, you would add all of that up. The total score dictates whether something is, quote, pathologic. So if your score is between 1 and 7, it's considered focal hirsutism and a normal variant, while a score of 8 or greater is considered generalized hirsutism and is less typical and should warrant kind of an additional evaluation. However, there's also, depending on the resource that you refer to, there's a lot of variability in what kind of the quote cutoff is. Some people say 6. And actually, I read one study that said a score as low as 3 is associated with androgen excess in 50% of cases. So maybe we should be having a kind of a lower threshold to investigate this further. The other issue this brings up is there's natural variation in hair growth across kind of racial differences. And so lower scores or higher scores may still be abnormal in that specific population. The next diagnostic criteria is the menstrual irregularities. These menstrual irregularities are the most common presenting symptom and frequently are present from onset of puberty. So from kind of their first period, they have irregular periods. As a brief review, a normal menstrual cycle is always regular, but varies between 21 and 35 days long. But whatever is normal for that patient is normal. In patients with PCOS, they frequently have oligomenorrhea, which is defined as less than 9 periods per year, or even amenorrhea, which is no menstrual bleeding for 3 or more months. It's important to remember that PCOS is a condition that affects women even before puberty, and we'll talk a little bit more about this in etiology. So if you are developing kind of a new onset oligomenorrhea or amenorrhea, say like in your early 30s, that is less consistent with PCOS and should kind of consider alternate etiologies of those symptoms. The last feature of the, yeah, go ahead.
There's a question in the chat from Becca Ellis regarding the Ferryman-Galway score.
Yeah.
About whether the patients do it themselves or you do it together.
I think that I've never run through the scoring system with a patient, but I would probably run through it with a patient because I think that kind of determining how, quote, abnormal something is often is beneficial from to have a provider involved. But given that things like hair growth there's lots of different ways that people can kind of self-treat that. You can't just do a physical exam and attribute a score. You have to kind of ask the patient about their symptoms. Does that answer your question, Becca? I'll assume yes. Oh, great. The last feature of the Rotterdam criteria are polycystic ovaries as seen on pelvic ultrasound. And there are actually 2 different ways to define polycystic ovaries, both volume greater than 10 cubic centimeters and the number of cysts. The cutoff that I saw was 12, but often patients with PCOS can have far more than this, like 25 cysts in their ovary. This is a more controversial addition to the Rotterdam criteria. Previous scoring systems from the NIH and the Androgen Excess Society required that high androgens be present in order to diagnose a patient with PCOS, while the Rotterdam criteria, you can combine these features in different ways. So you could have irregular menses and polycystic ovaries without hyperandrogenism and still get a PCOS diagnosis. It's thought that this scoring system better encapsulates the multiple phenotypes of PCOS seen. And although the hyperandrogenic forms are more common, it's becoming increasingly accepted that women with irregular periods and larger polycystic ovaries have PCOS, although this phenotype is less common. We can have, if we have time at the end, I can talk a little bit more about the different phenotypes and their how common they are. The other thing I want to say is that multiple follicles is a very non-specific finding. So if you get a pelvic ultrasound for another reason and happen to see this, if the patient is kind of having a normal menstrual cycle, it does not qualify them for a diagnosis of PCOS. Interestingly, though, there's actually growing evidence that this finding could be suggestive of mild insulin resistance and could potentially increase patients for risk of insulin resistance. Okay, before we transition into building a differential for these patients, I want to briefly discuss the epidemiology and pathophysiology. As I mentioned previously, PCOS is one of the most common endocrinopathies, and it's estimated that between 5 and 20% of the female population worldwide has this condition. It's actually seen worldwide at similar rates. It's commonly accepted that there's a strong genetic correlation for this condition. With the largest twin study performed demonstrated a monozygotic correlation of 71% and a dizygotic correlation of 38%. And the study authors ended up estimating that as much as 70% of the variance in kind of PCOS stems from genetic influences. So we really should be thinking about this condition more as an inherited or genetic condition or one that you kind of have from a young age rather than one that you acquire at age, 30 or something like that. Okay, so what even causes PCOS? And like many women's health topics, no one really completely knows, but it's thought to be related to abnormal GnRH pulsation, which is going to be in the upper right-hand corner of the screen there. The GnRH is being secreted more frequently, which increases LH hypersecretion. And this stimulates the ovary and causing ovarian dysfunction in kind of two different ways. One is that it stimulates more androgen production from the ovary, and the other is that it interferes with follicular development, which explains the menstrual irregularities. The hyperandrogens that stem from this actually end up negatively feeding back on the negative inhibition of progesterone on GnRH. So basically, progesterone normally inhibits GnRH, and when the androgens are stopping the progesterone from doing that, more GnRH is being released. So that further develops this PCOS phenotype. Okay, so we covered the diagnostic criteria, and I mentioned that PCOS is a diagnosis of exclusion. So we have to exclude the secondary causes of hyperandrogenism or irregular menstrual bleeding in our workup for PCOS. So I was hoping that in the chat box, you guys could name some conditions you would want to make sure to rule out before attributing a patient's symptoms to PCOS. Pregnancy, that's a great one. Another good one from Shiv. You guys are so smart. Those are all good suggestions. We have adrenal problems, ovarian cancer, pregnancy, congenital adrenal hyperplasia, prolactinomas or hyperprolactinemia, Cushing's disease, all great suggestions. The way that I kind of conceptualize the differential is into more common causes, so things that you should really be thinking about, and then less common causes. So more common causes are things like thyroid dysfunction, hyperprolactinemia or prolactinoma. Actual more common issue is 21-hydroxylase deficiency, which is non-classical congenital adrenal hyperplasia. And then endometrial or structural abnormalities, which a couple people mentioned as a potential etiology. We also need to be thinking about those rarer causes and kind of evaluating the patient and their history, whether these need to be worked up further. So those are things like Cushing syndromes, exogenous androgens, which I don't think anyone mentioned, but if someone's like taking steroids, acromegaly, primary and ovarian failure or hypothalamic problems, and then androgen secreting tumors, either from the ovaries or the adrenals. Mac, I actually have the diagram at the end if anyone wants to review 21-hydroxylase deficiency. So you're not safe. So the appropriate lab testing is built on the fantastic differential we just made. And conceptually, I break it up into 3 buckets. The first is to evaluate for other causes of irregular periods, which includes those endocrine disorders and pregnancy. I'll also consider getting an LH or FSH if concerned about hypothalamic dysfunction or premature ovarian failure, and a pelvic ultrasound to check for any structural abnormalities. Although the pelvic ultrasound is not required to diagnose PCOS if a patient has signs of hyperandrogenism and irregular periods, from my experience, most practitioners do end up getting that in order to look for structural abnormalities and just check the morphology of the ovaries. Then we need to evaluate for biochemical signs of hyperandrogenemia if the physical signs are subtle or difficult to determine. The single best test to get is going to be a total testosterone. Then there's a couple of other things that we can consider getting, like a 17-hydroxyprogesterone level if you're concerned about 21-hydroxylase deficiency, although there's certain timing factors that play into that, like you have to get it during a certain phase of the menstrual cycle. And then some other things like sex hormone binding globulin, DHEAS, which I've seen ordered frequently, although the reading that I did showed that there's kind of not a good way to interpret that test. And then some people get a free testosterone, although that's more expensive and more difficult to obtain than a total testosterone. The last thing you should check for is the metabolic abnormalities associated with PCOS, like insulin resistance and lipid disorders. I do want to say that when we're doing this lab workup, it's important to remember that if a person is on hormonal contraceptives, checking for biochemical hyperandrogenemia is less useful because those contraceptives are suppressing the gonadotropins and ovarian androgens. So ideally, if you're concerned, you should be stopping those medicines for 4 to 6 weeks before measuring these levels. The last thing I wanted to briefly mention is that women with PCOS can have mildly elevated prolactin levels normally, but a level greater than 40 is more concerning for kind of a primary prolactin cause. Okay, we covered the diagnostic criteria. We talked a little bit about pathophysiology, epidemiology, and how we're going to work these people up. So I'll take a little breather before we move into how do we treat PCOS. Okay. So let's talk a little bit about PCOS across the life cycle. PCOS is really a condition that affects women from adolescence all the way through menopause and beyond. I know not all of you are frequently caring for reproductive age women in your clinics, so I encourage you to instead consider how someone with PCOS or PCOS physiology might have increased or different risk factors for certain chronic medical conditions as they age. This isn't a condition that just goes away after menopause. Those underlying kind of metabolic disturbances are still there. So during the remainder of the talk, we're going to be discussing the management of menstrual irregularities, hyperandrogenism, and endometrial protection. We'll talk briefly about insulin resistance, cardiovascular risk associated with PCOS, and touch on mood disorders, infertility, and pregnancy outcomes. Okay, patients with PCOS have an increased risk of abnormal uterine bleeding, which can be disruptive, impair quality of life, and even cause such dysfunctional uterine bleeding that it can lead to anemia. The most common and well-tolerated way to treat these abnormalities in a patient not desiring pregnancy is combined oral contraceptives. They suppress gonadotropin release and will be a treatment strategy that we use for some of the other comorbidities that we'll discuss in upcoming slides. There are some side effects of OCPs, especially relevant in this population. Interestingly, they can have adverse effects on insulin sensitivity and are associated with increased triglyceride levels. Also, the risk of VTE is 2 times higher in women with PCOS on OCPs compared to the general population. So the risk is still very low, but it's an important risk to counsel your patients on before starting these medications. Okay, in terms of hyperandrogenism or hirsutism, the most important factor is to control the level of circulating androgens. And easiest, best way to do that is our friend, the OCP. Although no OCP has been approved for the treatment of hirsutism, studies have shown them to be effective, although there is some evidence that they're more effective with the addition of spironolactone. And I think that combination is an easy and safe starting point for the average internist. As a review, spironolactone binds the androgen receptor and inhibits steroid creation in the ovary and adrenals, competing for androgen receptors in the hair follicles, and even inhibits 5-alpha reductase activity, decreasing circulating testosterone levels. In terms of dosing spironolactone, you should be targeting a pretty high final dose of 50 to 100 milligrams twice daily. This can take a few months to uptitrate, and it takes 6 months or more in order to take effect. From my personal experience, most young women are not able to tolerate doses this high due to orthostasis, though. Also, any anti-androgen is a teratogen, and so reproductive age women on these medications should be using an effective form of contraception at the same time. You can also always offer cosmetic management to these patients, so mechanical things like waxing, shaving, plucking, and then laser hair removal. Other factors, things like acne, you can treat with topical agents or oral antibiotics, and then male pattern hair loss, some patients have some success with topical minoxidil or Rogaine. Okay, so any combined oral contraceptive should improve menstrual irregularities, but the progestin you choose has implications on androgen production. And this is getting pretty deep into selecting an OCP, but I think it's especially relevant in this population because you want to pick a progestin that is less androgenic to help ameliorate those symptoms of androgen excess. So you, or many of us, are most familiar with first and second generation progestins like norethindrone and levonorgestrel, but second gen progestins are actually slightly androgenic. So sometimes patients can notice worsening of their acne on that. Really, in this patient population, we want to be focusing on these third and fourth generation progestins. which have increased progestational activity and decreased androgen activity. And actually a 4th-gen progestin, which is drospirenone, you may have seen the ads for Yaz or Yasmin. I feel like that was a big thing, maybe 5 or 10 years ago, is a progestin derived from spironolactone and has strong anti-androgen and anti-mineralocorticoid properties. When prescribing Yaz, you may be concerned saying, well, if it has anti-mineralocorticoid, should I be worried about patients' potassium levels? You don't routinely need to monitor when starting this type of OCP, but if I'm starting this at the same time as spironolactone, I would probably be more cautious about regularly checking their potassium levels, or if they're already on spironolactone, you might have to come down on their spironolactone when starting this agent. The next risk I'd like to talk about is the risk of endometrial cancer and the role of endometrial protection. Your patients with PCOS are at a 3 times higher risk of endometrial cancer over their life due to the chronic anovulation and lack of endometrial shedding. Also, the chronic stimulation of the endometrium by estrogen with low progesterone due to the anovulation increases the risk of hyperplasia, and that can end up leading to carcinoma. Women with PCOS also have other risk factors for endometrial cancer like hyperinsulinemia, hyperandrogenemia, and obesity. There's no great way to kind of monitor or screen for the development of hyperplasia, but it should be considered in all anovulatory women with new or atypical vaginal bleeding, even those who are premenopausal. For treatment, any agent that decreases endometrial stimulation and promotes turnover is a safe option, like you guys guessed it, the OCP. In terms of other forms of contraception, progestin-only pills or IUDs can have endometrial protection, but are less likely to help with the abnormal bleeding patterns that many women with PCOS have. The last thing I want to say is if there's someone with PCOS who doesn't want to start a form of hormonal contraception, I would recommend prescribing a 5 to 10 day course of progesterone if they've not had a bleed in 90 days. And with completion of that course of progesterone, on withdrawal of the progesterone, that should stimulate the endometrium to shed, and that prevents the development of hyperplasia. If someone does that and still is having atypical or breakthrough bleeding, endometrial biopsy is a low risk and fairly easy in-office procedure, and I would kind of err on the side of caution in this patient population. The next comorbidity I'd like to discuss is insulin resistance. And most women with PCOS have some degree of insulin resistance, and it's present regardless of weight compared to age-matched controls. This is a fantastic diagram from the Polycystic Ovarian Syndrome Nature Review article talking about the different mechanisms in PCOS that are thought to lead to insulin resistance, but it really stems from kind of a dysfunctional adipocyte regardless of the patient's weight, that just processing of glucose in the adipocyte is abnormal. As we discussed in pathophysiology, this kind of feature of insulin resistance is not thought to be totally related to the increased androgen levels, but the increased insulin levels do contribute to hyperandrogenemia. Patients with PCOS, given their degree of insulin resistance, are also at higher risk of developing diabetes, 2 to 5 times higher than the general population. So the key is really to screen for insulin resistance and impaired glucose tolerance. A lot of the literature actually recommends doing this with a 2-hour glucose tolerance test, which is not something that I've ever prescribed in residency in internal medicine, because it's thought that a fasting glucose doesn't really accurately capture any degree of impaired glucose tolerance or insulin resistance. I think more realistically in our setting would be to get an A1C, which just better captures kind of the overall glucose trends. And if it's in that prediabetes range, that's what I would kind of consider insulin resistance. So how do we treat? Just kind of like any other patient with some evidence of insulin resistance, which would be to start an insulin sensitizer in addition to lifestyle interventions. Metformin is a really safe and easy starting point for these patients, even those who are fairly young, because the conversion from impaired glucose tolerance to type 2 diabetes per year is almost 20%. In high-risk patients, you can start these agents to help decrease the risk of conversion to type 2 diabetes. Metformin is also safe in pregnancy. Metformin is associated with decreased circulating androgen levels, improved ovulation rate, and improved glucose tolerance. And any improvement in insulin sensitivity is going to increase sex hormone binding globulin and decrease bioavailable androgens. it can also decrease the risk of conversion, which we talked about. Becca just asked a great question. How often should women with PCOS get screened? I think on initial diagnosis, and then the recommendation is every 1 to 2 years, depending on other risk factors. So more frequently than like the average 30-year-old. I also want to talk about cardiovascular risk. The cardiovascular disease incidence and mortality associated with PCOS is actually not completely known, and there's no prospective trial demonstrating an increased risk of cardiovascular events in this population. However, there are some retrospective studies that provide kind of some evidence that these could be related, including the Nurses Health Study demonstrated that there was a dose response risk of cardiovascular disease in the presence of increasing oligomenorrhea. So to kind of reframe that, the fewer periods a person was having per year, that was associated with higher risk of cardiovascular events, both fatal and non-fatal. We're not, though, able to definitively say that they have increased cardiovascular mortality given the lack of prospective trial. But there have been studies that say the thickness of the intimal layer of the carotid is greater, there's more aortic calcifications, there's more coronary calcifications, but there's obviously a lot of confounders in this, in these types of studies, and so more research needs to be done. However, we do know that PCOS is associated with elevated lipids. It's not completely clear what the clinical significance of this finding is, but borderline or high lipid levels are present in almost 70% of patients with PCOS, and it's disproportionate elevations of LDL. This is regardless of the patient's weight. PCOS is also independently associated with multiple psychiatric conditions, including depression, anxiety, and eating disorders, especially binge eating disorder. This is even when controlling for weight, hirsutism, and infertility. It seems that PCOS still confers an increased risk of a concurrent mood disorder. In terms of management of these patients, I would make sure to screen with a PHQ-9 and GAD-7 kind of on a routine schedule, and then make sure to ask about disordered eating habits and refer patients accordingly, because screening alone does not improve patient outcomes. Other medical conditions associated with PCOS that we didn't cover in this talk is it's thought to be associated with non-alcoholic steatohepatitis and sleep apnea, and also potentially an increased risk of venous, like VTE. So just know kind of in the back of your mind that those risk factors exist as well. The last things I want to briefly touch on are infertility and pregnancy. Even though we're not OB-GYNs, I think it's important to know about these risks so you can better counsel your patients. It's actually, PCOS is the most common cause of anovulatory infertility in the United States, and it's a super common issue in women with PCOS independent of their BMI. While a normally ovulating woman has about a 10 to 15% chance of conceiving per cycle, a woman with PCOS has a conception rate about half that at 5 to 10% per cycle. The big take home I'd like you to have is that it's important to refer these women to OB-GYN or REI or reproductive endocrinology and infertility for early evaluation. It's also really important to talk to your patients about their fertility goals in a low pressure way to connect them with the resources that they need to meet those goals. While none of us are going to end up being reproductive endocrinologists, I will say that one of the best studied ways to improve pregnancy rates in this population is weight loss. While it was only studied in patients with higher BMIs, a decrease in weight by as little as 5% is associated with improved ovulation and conception rates, which is thought to be mediated by changes in sex hormone binding globulin. However, this intervention has obviously not been studied in normal weight women, and there is kind of some equity considerations when discussing weight loss with patients, which I will touch on very briefly, but it could be an entire talk on its own. Last, PCOS is associated with negative pregnancy outcomes. Many studies describe an increased risk of early pregnancy loss, kind of unclear etiology, and you have an increased odds ratio of gestational diabetes, pregnancy-induced hypertension, preeclampsia, and preterm labor. The risk of gestational diabetes in patients with PCOS is unrelated to their BMI. I also want to say I just listed off all sorts of different scary things, and I'm sure there's plenty of people in the audience that actually have PCOS and they're like, oh my gosh, but I really think that it's an area of active research, and many of these conditions are highly treatable with adequate screening and counseling. I'm also hopeful, given a lot of these genetic studies, that we're going to be able to better understand the pathogenesis of PCOS, and we'll develop better ways of treating the underlying condition rather than the sequelae of this condition. Briefly, I want to touch on some equity considerations. I'm sure talking through this talk, many of you can think just off the top of your heads of different ways that equity can play a role in kind of unfair diagnosis and management of these patients. Firstly, in terms of differences in presentation across racial backgrounds, the idea of being, quote, sufficiently hirsued or having sufficient physical exam findings has known variability across racial backgrounds, and that could kind of bias us towards more aggressive or less aggressive treatment of these patients. I also think a lot about access to specialty medical care in these patient populations. I think a great example is infertility treatments. Who has access to infertility treatments? Who gets referred early, depending on kind of their other risk factors. Also, in terms of gender identity, PCOS really should be considered this genetic kind of underlying predisposition. So even if someone isn't having periods or is taking kind of exogenous androgens like testosterone, those underlying metabolic disturbances are still there and should be considered in terms of risk factors. The last thing I want to talk about in more detail is kind of weight stigma, is that you guys heard me multiple times in this presentation talk about, oh, weight loss is a strategy. Patients with higher BMIs are associated with this or that. And so that may make you think that weight and PCOS are strongly correlated. And there are studies that suggest that, but when you look more deeply into those studies, it turns out that the vast majority of studies correlating obesity with PCOS recruit patients from a hospital setting, which means it's biasing those studies towards people with one, higher healthcare utilization or healthcare access, and also those with more severe phenotypes that may be referred to a specialty setting. In the few population-wide epidemiologic studies, the association between weight and PCOS is less clear. Also, the prevalence of PCOS across the world is roughly the same, even though the mean BMI between countries varies very widely. And last, the genetic studies done thus far demonstrating kind of genetic correlation demonstrate no association between genetic variants in genes involved in obesity and those involved in PCOS. So I just want to say that final reminder that obesity is not a diagnostic criterion for PCOS, and many women with PCOS are not overweight or obese. This is an area of active study, and it's an important reminder to us as healthcare providers about the role that weight stigma can play in our counseling and diagnostic decisions. Just because someone is above kind of a prescribed, quote, normal weight doesn't mean they have PCOS with these symptoms. And just because someone is a, quote, normal weight doesn't mean they couldn't have PCOS. Rita, could that be because BMI is not a good predictor of central adiposity, which is really the cause of insulin resistance? Like South Asian women tend to have much higher abdominal obesity at the same BMI. And Kevin, I totally agree with your point about establishing BMI using white bodies and just finding kind of an average white male body as an ideal body weight. I think those are all great suggestions. And when you look at these studies, even if it's a study just done in the United States, this is like all selecting for certain patient populations and characteristics. And we just don't know enough about PCOS, and not enough research is being done to better understand these different risk factors. I really appreciate those contributions though. Okay, we have a short 5-question quiz to test our learning. So we are on our first question, and I appreciate Shri and Javel getting those set up. The first question is, which of the following 3 clinical features constitute the diagnostic criteria for PCOS? Okay, am I in charge of ending the poll? You guys are so smart. The answer is D, hyperandrogenism, menstrual irregularities, and polycystic ovaries. It's a good question about insulin resistance. Although PCOS is associated with insulin resistance, it's not one of the diagnostic criteria. That those Rotterdam criteria is 2 of those 3 criteria. Question number 2 is, what is the best first test to order in a patient to evaluate for biochemical evidence of androgen excess? The correct answer is B, total testosterone. The other answers selected, DHEAS and free testosterone, are definitely things you can consider getting. Total testosterone is the cheapest and easiest test to get. That's the easiest to interpret. DHEAS, it sounds like if those are elevated in the absence of a testosterone elevation, it's harder to interpret. And then a free testosterone is just a more expensive test that can be useful, but ultimately the total testosterone is usually an accessible test for most labs. Question number 3, what other medical conditions should be screened for in patients with PCOS? Type 2 diabetes, adrenal insufficiency, lipid disorders, and mood disorders. And then option E is type 2 diabetes and mood disorders. F is type 2 diabetes, lipid disorders, and mood disorders. And G is all of the above. Oh, they're a little different on your poll. That's okay. The correct answer is G, A, C, and D. So adrenal insufficiency is not associated with PCOS, and lipid disorders are. I appreciate your guys' participation. 2 more questions. Question 4 is, a patient with PCOS is very concerned about progressive dark hair growth on her upper lip, chin, chest, and abdomen. What treatment options can you offer this patient specifically for this complaint? We have metformin, OCPs, spironolactone, and laser hair removal. Correct. The answers are combined oral contraceptives, spironolactone, and laser hair removal. When I ran through this presentation with my parents last night, they said all of the above. And I actually think it's an interesting argument, is that we said that metformin decreases circulating androgens and kind of helps promote insulin resistance, or decrease insulin resistance, which feeds back on all of these pathways. And so I actually think it's an interesting argument that if someone has another indication for metformin, it may help them with some of these symptoms. But in the absence of insulin resistance, I think that some of these other options would be better. Our last question is, following menopause, does the incidence of the comorbidities associated with PCOS return to that of the general population? No, they don't. That those conditions, the kind of underlying metabolic disturbances persist and may increase risk of cardiovascular disease or lipid disorders or insulin resistance and type 2 diabetes post-menopause as well. Great, you guys passed the quiz. To wrap things up, I just want to summarize what we learned, which is that PCOS is defined by the Rotterdam criteria, which includes hyperandrogenism, menstrual irregularities, and polycystic ovaries on ultrasound. You need 2 of the 3 to meet diagnostic criteria. I also wanted to remind us that PCOS is a diagnosis of exclusion, and you need to rule out other causes of menstrual irregularities or hyperandrogenism before assigning this diagnosis. These may include things like thyroid disorders, prolactinomas, androgen-secreting tumors, 17-hydroxylase deficiency, Cushing's disease, endometrial abnormalities. It all depends on the patient and their presentation. Also, we reviewed that there are multiple gynecologic and medical comorbidities associated with PCOS, and it's important to ask patients about these, including abnormal uterine bleeding, endometrial hyperplasia or neoplasia, insulin resistance and type 2 diabetes, cardiovascular disease, hyperandrogenism, infertility, and pregnancy complications. Last, there are multiple opportunities for bias in diagnosing PCOS with respect to weight, race, gender identity, and more. We specifically discussed the lack of definitive evidence that obesity is even associated with PCOS and its pathogenesis, and it's unlikely that weight alone is the primary driver of PCOS. We should take care that patients don't feel responsible for this diagnosis. If you found this talk thrilling, I have a couple of recommended resources for you. ACOG has a fantastic PCOS practice bulletin, and they actually have practice bulletins about many common gynecologic or obstetric conditions that I find really useful if I have questions. There's also a fantastic Nature review primer on PCOS that delves more deeply into kind of the genetic research being done and the pathophysiology of PCOS as it's currently known. If you're looking for more clinical experience, there is a women's health elective that you can do in your R2 and R3 year, where you can have more experience taking care of women kind of across their lifespan. I specifically want to thank Addie McClintock and the other women's health faculty for helping me conceptualize this talk and review my, my data, and then my favorite co-resident, Luke, and then my parents, Janet and Pete, who helped me troubleshoot some Zoom issues and support me emotionally in giving this talk. I would be happy to take a few questions in the last few minutes that we have.
I had a question.
Yeah.
So with the menstrual irregularities, if someone presents with sort of like abnormal spotting or just irregularity that we wouldn't necessarily characterize as amenorrhea or oligomenorrhea, is that sounds less likely to be PCOS?
It's hard to say, you know, if it's just like if someone has a regular period, say every 27 days they get their period and then they spot like with intercourse, I think that that's less typical for PCOS. But if someone is just kind of having pure irregular periods, even if they're like, well, I'm just kind of spotting every few weeks or every few months, I think that that is more consistent with kind of irregular menstrual bleeding. And you can ask a few more questions kind of about what that entails.
Totally off subject here, but is Addie McClintock related to the Martha McClintock who described menstrual synchrony?
I don't believe so.
Okay.
But she's a very nice person.
Yeah.
Thanks, John.
I had another question.
Yeah.
So if I have in terms of the workup, so if I have a patient who does not have clinical signs of hyperandrogenism, but has menstrual irregularities, just to confirm, the first test that I should do is probably a total testosterone on this patient and or get a transvaginal ultrasound? Yes,
in that patient of kind of true menstrual irregularities, or at least it's concerning enough for the patient, that's when I would investigate the biochemical. So with a total testosterone, look for other causes of irregular menstrual bleeding, so thyroid, prolactin, things like that. And that's when I would get a pelvic ultrasound, because if it turns out she has a polyp or a fibroid, maybe that's contributing to her regular bleeding instead of just kind of attributing it to PCOS. Does that answer your question, Annie?
Yes, that I can get the biochemical studies and a transvaginal ultrasound in at the same time, not in sequence. Okay.
I think that's totally reasonable.
Awesome, Nikki. Thanks so much. And I especially appreciated your equity pearls. We are going to take a 10-minute break.